finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
All right, everybody. Thanks for tuning in this week. It's May Hindmarsh and my co-host, Tim Hindmarsh, dual physician couple here with BS Free MD podcast. In case you're tuning in for the first time for this cool episode
and if
this
you
week.
are, what is wrong with you?
Seriously. Yeah, that was in my head, but I'm more polite than you. So anyway, this week, this is a topic near and dear to my heart. And I know a bunch of you are or have been asking questions. We're touching on migraine headaches, but in a different way. Our guest today is actually Dr. Jono Taves. He has a doctorate in physical therapy and is the owner of the Novera Headache Center in Colorado. And what's really unique about his approach to migraine, which we'll get into, is that he really thinks, and I believe that migraine is an understood process in a lot of people, that migraine can be treated without medicine in certain conditions, especially when tension headaches and underlying neck conditions are involved. And he's got a multifactorial approach, which I appreciate because I believe that as well. And so he's here to talk to us today about who needs proper evaluation and what you look for in a migraine provider, as well as how migraine symptoms can be triggered from the neck, and also, most importantly, how movement can be medicine, which I love. So with no further ado, here is Dr. Jono Taves. Welcome to our podcast, BS Free MD. I'm super excited you're here. So is Tim.
All right.
Yeah.
So
Thanks for having me, guys.
Yeah, you bet.
Why don't you tell us a little bit about just your background? I mean, I know you have a doctorate in physical therapy, your training, and how did you get interested in migraines of all things, and that led you to forming your center?
Yeah. So most people are not going to associate physical therapist with headaches or migraines. And so it is an interesting story. I started at the Mayo Clinic. That's where I got my physical therapy degree. And not to say that what I express here is a reflection of the Mayo Clinic. I went through their program, and in their program, I actually got to connect with a few physical therapists that were doing what was called manual therapy. And so it was physical therapy, restoring function to the body, but using their hands. And I got really excited about it because the impact that these providers were having on patients was significant. When we think of physical therapy, oftentimes, in the outpatient setting, it's a big open gym and you're taken through an exercise program, and maybe you're working with a tech or an aide and you're like pulling on some bands. That didn't necessarily excite me as much, even though exercise and that can have its value. I got excited about this hands-on approach to care because these providers would have people travel from all over, and their patients would get better. The other thing that these providers were doing is they were working on the neck and the jaw. And so they had a good understanding of the biomechanics behind the neck and of the jaw. And so they would use their hands-on techniques to restore function to these areas. One of the things that is connected, as we'll talk about, is headaches. So this referral pattern from the neck can cause headaches. And so I was trained up under different types of manual therapists. And so I started treating people with headaches right out of school. As I saw patients with headaches, all different types of headaches, occasionally I would get a patient with the diagnosis of migraine that would come across my schedule. Now, at first I thought, well, migraine it's this neurological disease. The neurologist needs to see them. You just need medication. Okay. So, but what they said was, I've seen 3 or 4 neurologists in town and I am miserable and the medication has not helped. All right.
Bingo.
Yeah, exactly. Yeah. How many listeners can relate to that? So
You're not spending enough money on medication, obviously.
Right. The answer is more medication. What I did was I applied this same evaluation and treatment process to their neck primarily. And I was finding that they had these same restrictions, the same problems. We can call it an injury, a type of injury to the neck that was referring pain and causing these symptoms that are consistent with migraines. And applying the treatment approach, they would get better, like substantially better, to the point of almost to the point of they didn't have migraines anymore. And this kept happening over and over again. So over the course of a year or two, I'd seen a couple dozen of these migraine patients, and I almost had like 100% track record. It was just like, what? These people's lives are dramatically improved. And so it was so exciting that I saw problems within our healthcare world, and specifically the physical therapy world. And then I saw this disconnect between, what these patients were provided as a plan of care, and then what they truly needed. And then to build trust with people that had migraines, because generally as they're going through their healthcare system, they start to get skeptical that there's an answer. And so what I did was I created this center that all we do is treat people with headaches and migraines, and applying these same techniques, the evaluation and the treatment plan of care. And it's been amazing. So we've been open. This is year 5. And through the podcast and social media, we are sort of amazed at how big of a problem this is. And so we're just trying to provide people with education and an opportunity to have something outside of medication to manage their symptoms.
I'm excited. From my point of view, you could have one of those centers in every state and still be underserving the community, the medical community at large. Because from my experience personally, as a person that has had migraines, but also as a doctor throughout our years in family practice and urgent care, it's such a common issue that we see, that people don't understand the connection between not even just with migraine, but their body and then their pain. And that a lot of the time the referred pain stems from another source, but especially in migraine, because the back, the neck, the tension is what can be one of the biggest triggers. And medications, abortive medications, preventative, that's great. But if you can fix the underlying problem, and for most people, the underlying problem is their functionality, which is what's going on with their neck and their back, whether, they've had an actually car accident. And I've had that, and I know how big of a problem that can be. Just the way their posture is. I mean, I'm sure you'll get into all of that, but for the most part, you're right. It's I think one of those things we don't focus on that much,
But
or as much as we should.
But what's really interesting to me is we've known this for a really long time.
Oh yeah.
Because like if you look at the emergent therapies, we've been doing this for about 30 years. And if you look at the therapies that came through, so, there was, ergotamine, which is ancient. So it was migraine is a spasm of blood vessels in your brain, which may be the final pathological pathway, but it's probably, clearly for most people, it's probably not what starts it. So, once you get this headache, then you take these abortive agents that cause vasoconstriction, which then, stops the cycle and the headache gets better. So then we went down this path, and then we went down, different NSAIDs, and then, they got triptans, which work on a different receptor, causing, all this vasoconstriction thing. But then all of a sudden, out of nowhere, about 20 years ago, comes Botox.
Yeah.
Well, Botox is only relaxing muscles on the surface. We're not injecting Botox into your carotid artery and then into your brain. I mean, you could try, you'd get to do it once, and that would be that. And then we started the data that we've, collected over the last 20, 25 years with Botox. I remember when it first came out and it was like black magic voodoo. It was like, well, this isn't going to work because it's a muscle relaxer, essentially a paralytic agent for muscles in your head and neck. It's not going to work. This is voodoo. 20 years of data was this is actually the thing that works the best in the medical industrial complex. So all of a sudden we're like, oh my gosh, there's something outside your head that affects this headache inside your head. And now that we have a way to patent a medication and a technique and charge thousands of dollars per therapy, well, all of a sudden it's something that we should do.
Yeah, we put some dollars behind it and then it makes sense.
Right.
Yeah, and actually, so what you're hitting on there is the journey I went on was to uncover what these neurologists were doing and why why our healthcare system was set up to funnel people straight to the neurologist office. And so, I mean, if you dig into the research, it really, as you said, Tim, it's like this circular reasoning in a sense where you have the symptom. And I think a lot of these medications, it just like they weren't being prescribed to these patients with migraines for migraines, but they just happen to help. And then it's like, well, let's explore this. And you continue to research that. And okay, so a medication that has an impact on blood pressure, a heart medication like propanolol or something like that. Okay, well, so this has got to be a vascular issue. Like that's got to be it. And so, yeah, you're right. Like that understanding of or assumption of this is the underlying problem really limited the sort of research in the direction outside of that. But also as a provider, if you weren't confident on your understanding of this condition, then the assumption was, well, this is a blood vessel issue, and meaning medication is the proper treatment approach. And so the musculoskeletal pathway has been missed because of this sort of circular reasoning. And the whole paradox of this is that Botox works. And like you're saying, it works because it's treating the musculoskeletal system, or at least it's numbing it or paralyzing it so that it can't be an issue anymore. And so what we should do is continue down this path of, okay, why are these muscles causing this pain pattern? But we stop there because I don't know, it's a moneymaker. There's a lot behind this that the pharmaceutical companies, if it goes to the extent of, oh, this is a musculoskeletal issue, their fear is that a medication isn't going to be the answer. I mean, I would guess, but I'm speculating there.
Well, that's absolutely, because that's where the money's at. But even dialing it back, like Tim said, I knew as a kid that there was a musculoskeletal component with migraine. My mother had migraines back in the day when, the doctor would come to the house, make house calls and give her morphine, and she'd be locked in her room for 3 days. But she would go to her chiropractor and sometimes, get adjusted with a migraine, or, when she felt one coming on, and it would be 50-50, but a lot of times she'd get good relief. And as a kid, I go, something's up with her neck or something that triggers these. I mean, I could see that. And then even throughout our careers, like our training, my practice, I just with my own experiences, had more input and bias. And I knew that massage therapy was good for my patients. I would recommend chiropractic treatments in certain cases, heat, stretching, things to treat the musculoskeletal system. But man, it was sometimes hard to get a patient to buy into it, especially when their insurance isn't going to pay for that stuff, right? And that's like the big problem, is that when your insurance company doesn't want to pay for that, but they'll pay for the OxyContin or the Vicodin pill, you're stuck. And then of course people say, well, I don't have any money to pay for that, so just give me the pills. And then, well, how come it's not working? So we're still in that situation, unfortunately, even in 2023 now, where I think more people are aware, and patients and networks and groups online and communities where people, I'm on a Facebook chat group for migraines, and people share information about what works for them and doesn't. I think patients are becoming more aware. But I just wish practitioners would be more aware and really push for people to get proper evaluation before they jump into the pills.
Yeah. So it's asking the question why. So if you ask why, and then it takes you to the end result, right? Like you just keep asking that. As providers, I think oftentimes it's easier just to stop at, okay, there's some sort of solution or something that will manage their symptoms. I think a lot of migraine patients are sort of seen as the black sheep in the healthcare world. Like providers don't want to work with them, mainly because I just don't know if as a provider, they feel like they can be that helpful to that patient. And then oftentimes there is almost like this like psychosomatic component where it's almost assumed like you're making this up because I can't see it. I don't know how to help you because I can't actually physically test anything, which brings us to the evaluation process. So we're going to assume that there's a neck problem. If you have any sort of head or facial pain, in our practice, we're going to assume you have some sort of neck, jaw, shoulder issue. Now, if you go to your like a primary care doctor's office, and you guys can attest to this, the process that the gold standard as far as how do you screen for the neck is just checking range of motion. If there's pain at end range, if range of motion looks relatively normal, just actively. If they're coming out of a car accident within the last couple of weeks or so, you definitely want to do imaging if the range of motion isn't full. And but if you want to take it to the next step, like most of my patients can turn their head left and right, and it appears to be full range of motion, and it's not like painful. It might just feel a little restricted. So they would pass. Like they would pass that exam and be like, well, your neck is relatively okay. And then you go to an X-ray or maybe an MRI or something like that. The problem there is that there's still images. So the piece of information that we're missing is the biomechanical component, like how the neck moves, how it's supposed to move, how these joints are all set up to allow us to rotate, look up and down, side to side. And so taking a still image like an X-ray and MRI doesn't give us that information. So X-rays and MRIs aren't useless, but I need to understand how the body's moving. And that's where the problem really lies. And that's why physical therapy, in what I do, we're sort of trained and positioned to address this sort of problem, because what we're finding is that it's a movement problem. So for example, when you turn your head, about half of your rotation should come from C1 and C2 interacting with each other. So C1 shaped like a donut, and it sits on C2, which has a thumb-like structure. And every time you turn 45 degrees or so of rotation comes from there. Now, we can compensate really well. And that's why in the office, if I just have you do it, if I look at your general range of motion, I might not catch it. There are little compensation patterns that can pop up. But then outside of that, the X-ray, the still image doesn't show that. And so that's why I need to actually physically put my hands on someone's neck and understand how their movement looks. And then our process is really restoring that. And so when it comes to the evaluation of someone's neck, there's these components of it that are missing. And that's why we talk about bringing in other healthcare providers, other specialties, at least in my experience, going alongside schooling with MDs, I don't know if they're quite equipped to understand that biomechanical component and test for that. And I can't say all physical therapists are either, but that background, that foundation is there for us to step into that space, if that makes sense.
No, what you're saying is, I mean, correct. The training that we got, and I think it's pretty much the same as far as examining a neck through its range of motion, is this basic, watching, maybe palpating a little bit for obvious things, but we're feeling for like lumps, bumps. We don't know how to assess how the movement of the spine on, C1 on C2 is supposed to be. Absolutely not.
Well, but we shouldn't. That's not our job.
Right.
I mean, you come into an urgent care after after the Ravens won the Super Bowl and you fall off the back of a pickup truck, like happened to one of our patients, and one of our very astute physician assistants actually palpated the guy's neck and said, I think this guy needs a backboard and a CT scan.
Yeah. Oh, man.
And he'd broken his neck. I mean, that's our job,
Right.
Neck's not broken. Next patient, please.
Right.
But even I'm just thinking myself, with all the even experience I've had with personally having been through PT, chiropractic, DOs, work on my neck. I haven't been really instructed or taught. I can kind of figure it out a little bit, but I don't know what I'm doing as far as resolving that. So yeah, in med school, no way. Now, someone that's gone through a DO program, and if they've had a lot of training, and that absolutely would make sense. And because that's what they're trained to do, is the chiropractor. Right. But no, a medical doc, no way. I mean, it's just the visualization.
I think I can
Botox feel trigger points really well.
But I think Botox is the ultimate metaphor for this. It's the medicalization of how we do stuff. It's like, okay, it's a musculoskeletal system problem. The muscles are tight, so just paralyze those sons of bitches. like how does that make any sense? Right? It's like, well, you've got a bug in your lungs, so we'll treat you with, moxifloxacin or some god-awful antibiotic and wipe out your gut microbiome. But by golly, we killed the Nazis. And it's just like, it's this completely unbalanced way to look at things.
But if the physician recognizes that it's like, they got a musculoskeletal problem, it's not my wheelhouse. Obviously, they need to see someone. Then the next step is, well, who do I send them to? And we argue about this. Do they just need massage to loosen the muscles? Then it's like, chiro, for a long time, chiropractic, bad, evil, they're going to do things they shouldn't do, or some believe in a combo, or no, you need acupuncture, or somebody might go. Then there's the physical therapy route, because often that's covered.
Well,
So we don't
but
even
you
agree.
forgot the cure for everything, which is cannabis, obviously.
And there's that too now. Yeah. So we don't even agree amongst the physical specialties about which is the best route to go. And so
Yeah.
what are your thoughts on that for practitioners, but also patients? It's when they go to see their doctor and they like, yeah, I think I need some input, like functionally, where do I start?
Yeah, that is a tough thing. I will acknowledge that the system is not stacked up to easily funnel like someone with a headache or migraine that has this neck problem. They're at a disadvantage, and they're probably not going to find the right provider that they need. As far as what we do, just to sort of bring clarity around, like, okay, I have this neck problem. Maybe if you're a listener and you have headaches or migraines and you've tried pursuing this neck issue, because a lot of people intuitively think their neck is a problem, they'll go to a chiropractor, they'll get massage. Sometimes those things don't work. And so I guess the response to that isn't necessarily that your neck isn't the problem. I do think from a provider perspective, if they make that referral to like the chiropractor, to the massage therapist, and then it comes back and the patient's like, well, that didn't really work. What happens from a provider perspective is then they go, well, the next patient that has potentially this neck problem, I can't trust that they're going to find relief, and maybe that reflects poorly on me. So then, then they get stuck in this medication cycle. So not having a good solution as far as addressing these physical problems, the musculoskeletal issues, is a problem in itself for the MD that's trying to refer out. So when we think of, so chiropractic, as you said, is probably at the top of people's minds when they have a neck issue. One of the main differences is chiropractic, and I'm going to paint with a broad brush here, but chiropractic generally is looking at alignment of the spine, whereas physical therapists are trained in how to restore movement problems. So we want the body to move the way it was intended to. And so we're not really focused, like I said, the x-ray, it has some value, but I really want to know how people move. And when it comes to this headache and migraine issue, it comes down to some specific joints in the upper part of the neck. And if we think of our 10 to 12 pound head, there's a lot of stress. There's a lot of different reasons why someone would have this neck issue. And what we do that allows us to be a little bit unique in our approach is we address those specific joints through what joint mobilizations, these manual therapy techniques. Now, those techniques, it's not as if I created them. They're out there. There are other providers that do them. I just earlier today interviewed another physical therapist who is in this space, but I think he's the second of 3, maybe 4 physical therapists that are actually branding themselves as headache and migraine specialists in this space in the country. And so finding what we do can be a little bit challenging. So what do we do from there? As a provider, you're looking to refer out. Massage can be good. Chiropractic can be good. If there's a solid manual therapist, so someone who's trained in how to use their hands in physical therapy, I would say that's probably going to be a good avenue, because even though they might not say, they're a specialist in headaches and migraines, they're probably going to know how to do something with the neck that's going to be beneficial. And what I would say is, so when people interact with a medical doctor and say that medical doctor has a plan of care that is ineffective, people will almost never just throw out medicine. You just find another provider. And so what I would encourage people that are searching for relief for their neck issue, or they intuitively think their neck is the problem, keep searching, because whether you're listening to this podcast, I mean, obviously I can be a resource, but keep searching, because you as a patient should be listened to. And if you intuitively think that my neck or my shoulder tension is leading to a lot of these problems, then pursue that and keep pursuing it, and find an MD or your primary who can connect you with the right person. Like, just keep pursuing that.
So the big question for me is, what do you do? Like, is this a program where, patients would, in your situation, have to live in Colorado Springs and come and see you twice a week for the next 6 months? Is it, they get seen a couple times, and then you give them homework and they do, homework, and then they're fine. Is there stuff they can do with an acute headache? Because, that's what we see. That's our world. We see the people that are either utterly debilitated for a few hours, or they have kind of, status migrainous, and they've, been in this cycle for a week or two. And it's like, I need to do something. Just give me anything. Cut my head off. I don't care,
Yeah. Yeah, that's a good question. So a few things there. If we function as an urgent care and I saw your patients come through our doors, I would venture to say that most of them we could help same day. Okay. And I'm putting that image in your head because oftentimes physical therapy is seen as like this long drawn out experience, and you have to like wait and put in the time and the money and the effort to get the result, which that is not wrong, but we get really excited first day of treatment because people typically walk out of here feeling some relief. Now, most of our patients have had a decade plus of chronic migraines. They've dealt with, I would say most of them, it's a weekly basis. They're dealing with something and they're debilitating. I mean, it's classic migraine. Like the migraine diagnosis is provided to a very high percentage of our patients. And so that's who we're dealing with. And the process we take them through, we do like to get people, I mean, we're in Colorado Springs, Colorado. We have people that fly in from out of state. We have people that drive from around the state. But it's a couple times a week. We want to see you. And it's about a 2-month process. So, I mean, in perspective, like it's really not that long when we're thinking about decades worth of headaches and migraines. And by the end of, let's say 8 weeks, we want to reach 80-90% improvement. Now, as far as like symptoms, we want the patient, how we measure that is really, it's more subjective. So, as we're going through the process, we remind people of their reality when they started. This is the frequency, this was the intensity. Where are you at by the end? And we want them to be saying 80-90%. And then past that 8-week period, we talk a lot about behavioral modification, the activity level that you have throughout the day, incorporating regular exercise, and so that we can maintain these results. And then if you are in town, oftentimes we have people check in with us once a month because that's better than risking, like they want that insurance policy.
I'm nodding my head as a migraine person, knowing things aren't feeling good.
Don't nod it too vigorously. You'll screw up your C1, C2 axis.
That's right. Yeah. And then people that fly in from out of state, we usually do a 1 week or a 2 week sort of program where we see them every day. And that's been pretty effective. And then we have a health coaching component where, we have a lot of people that reach out to us from across state lines that can't travel. And so what we've done is come up with online courses that people can take to just understand this problem. And then sort of a general exercise program, like specific to the shoulders and the neck, that people can go through to self-treat. And then we have a health coach that basically keeps them accountable, creates goals. Like, how can we just make you healthier? And believe it or not, like we have really, really good results with that program without us even applying these manual techniques. And that's where we've continued on this journey, and we just see the benefits of just general health are incredible to people in these situations.
So do you get into specific migraine diet stuff? Because I know for a lot of people, that's a huge deal. I used to not believe patients when they tell me what would trigger their migraines. And then I worked for about 10 years and I go, yeah, anything. For one woman, it was like a certain fragrance. And I go, you're just making that up.
You're nice.
No, but I mean, like, come on. It's like you smelled something, you got a headache. Yeah, right.
But
I'm like, yeah, that's exactly right. That's exactly what happens to people.
But I'm only laughing because he's an intelligent, really good doctor, and he doesn't believe this, right? I mean, I know it as a patient, but
Patients
I understand.
Lie all the time.
But it's hard to understand a smell or a certain food, tomato or barometric pressure change. I mean, I can rattle them off, but he's like, there's no way. So
let me kind of explain that because I think it can be helpful in the context of migraine. The experience that people have is not only it's confusing in the type of sensory inputs that are just like aggravating. lights and sounds, they're ultra sensitive to. Maybe they have like numbness, tingling that accompanies, the actual pain itself. Maybe they have an aura, so a visual disturbance. So all of these things can be very confusing. And that's why just chalking it up to this neurological problem that leads you down the road of medication is the route that we've taken. But what happens, and I could talk a lot about this, but I'll try to summarize it. So let's imagine the upper neck, the upper part of the neck. So anywhere from C0 to C3. So just the first 2-3 bones in the upper part of the neck, they receive sensory input. So these sensory afferents, these nerves running from that part of the neck, go through the brainstem in what's called the trigeminal cervical nucleus. Okay. That trigeminal cervical nucleus also receives input from the trigeminal nerve, which is going to pick up sensation from our face. And then it sends a common signal up into the brain. And so the way pain works is we don't actually experience, and really any sensation, we don't actually experience it until it hits our brain, our cerebral cortex. And once it hits our cortex, we realize what's happening. And so if you have a very intense pain signal that's sent from the upper part of the neck, and it meets up with these other nerves, and there's a lot of other connections outside of that trigeminal nerve, but that's just the easiest one to connect to. It meets up in the brainstem, and then it sends that signal up into the brain. So a couple things that will happen is the brain not only gets the location of the pain wrong, we call that referred pain. And that happens, the easiest example is, think of a heart attack, right? Your shoulder hurts. There's nothing wrong with your shoulder. It's your heart. Your brain just thinks something's wrong with your shoulder. Okay. So the location of the pain, it gets wrong. So the pain is in your head. And so it's natural for providers to think, well, we need to do imaging of the head to make sure you're not dying. Yes. Like, let's make sure you're not dying. But after that, what do? All right. That's where we lose patients.
We go to the next patient.
Next. It gets the location wrong, but it can also, the intensity of that pain signal can be enough where every other sort of input traveling through that same channel can have a hypersensitivity to it. Yeah. Okay. So think of this visually, your sense of smell, all of these sensations, these afferents. So they're sending signal, they're sending sensory input into the brain. The brain now has a hypersensitivity to them. So things like strong perfumes can be triggering because the brain is basically, the alarm signals going off like all the time. Okay. Because this neck problem's there. The alarm signal's going off. And think of if the alarm was going off in your house, how annoying would it be for me to like yell in your ear as well? Like it's just, you can't tolerate anything else. And so the brain's just getting bombarded with this pain signal. And it gets the location wrong, and then it pulls in these other sensory inputs. And that's how I kind of explain the experience of a migraine. It's the neurological system is definitely involved because of that hypersensitivity component. And then when we think of general health, there's a lot of ways that you can manage that threshold. So the sensitivity level so the environment that your brain is getting this pain signal in, we can modify that and control that. A little tangent here. You mentioned barometric pressure. Think of the patient or someone in your life that has a total knee replacement. They can always tell you when it's going to rain, when the barometric pressure is going to drop, right? They say my joint hurts and it feels stiffer. So if we're looking at a neck problem where there's inflammation within the joint because the joint's irritated, okay? So the pressure within the joint itself has been increased, and then the barometric pressure outside drops. Well, that delta, that change, just like the total knee, where that joint's can be irritated, same is true for the neck. So that irritation can increase with pressure changes. All right. So when we think of joint pain, joint problems, we know that barometric pressure is going to impact those. And so the same thing can apply to the neck. And that's why people with headaches and migraines can be triggered during that time. And then when we talk about environments that the pain is experiencing, that's where we get into things like diet, gut health, systemic inflammation. How do we manage those? Now, you asked if I put people on certain diets. So you said that evaluating the musculoskeletal system and biomechanics of the neck is not in your wheelhouse. That's not necessarily in my wheelhouse. Like,
right.
I'm not going to give people a specific diet. I'm going to send them to someone who can prescribe specifics, but I will give you generalizations. If you want to do an elimination diet, or avoid certain food groups, that's great. But in general sense, like in moderation, if you're exercising, if you're eating in moderate, like all of these things within this happy medium and not in the extremes is usually okay for most people. And so just a little education to push people in the right direction and say, like, you can actually make change to your situation and validate that rather than just saying you have to take this medication is empowering for people. And then they start making these changes and they say, like, oh my gosh, this is actually working.
I love your explanation neurologically what's going on. You did a great job because I struggle with that. But I think people who have allergies understand that it's the same thing. It's like, well, their asthma or the allergies can be not that bad, but you add the cat and then you add spring flowers and then you add a whole bunch of dust in the house and all of a sudden you're out of control. Whereas you can tolerate those things pretty
But
much
when they come in and talk to you, it's always black mold. It's never that they have 17 cats, 2 dogs, never vacuum or wash their clothes.
So
it's always black. I have black mold. No, you have a feline problem.
But you make me laugh and you get me distracted every single time.
Well, that's worked for 31
There
years.
you go.
Let's keep it going.
But it's the layering on of the triggers. Then I tell people it's like a branch with weight on it. It's bending, and it's holding up all this bird's nest, all this stuff, and then finally there's one little light thing that gets on there, it snaps and everything breaks. And so with migraine,
then a hummingbird comes and sits on it and it breaks, and the medical system goes, kill the damn hummingbird.
Exactly.
Right.
So migraine, as we're talking, gets misdiagnosed a lot. I mean, we know that. That's what is true migraine. But B, migraine can come from tension in the neck, like tension type headaches. So it's really a tension problem, a functional problem, like what we're talking about. And then that's not, if left treated, can turn into true full bore migraine with the auras and the flashing lights that people experience, the unilateral, the one-sided eye pain. And for some people, they don't have tension in their neck or a neck problem.
Yeah.
They just have a neurologic disorder that is migraine. And so my question to you is how often, so you've got this great success rate, which is awesome, but how often do you see people where they come in and get evaluated? I'm just going to guess not very much if they've had all these treatments already, nothing's worked, but where you go, your neck's great, there's nothing wrong with your neck. I won't say nothing I can do for you, but it's truly something else with the combination of all the other factors, but your neck's okay. How often is a neck never an issue?
Yeah, that's a good question. I will say that it's rare. It's very rare. I don't know if these patients that don't have neck issues just aren't finding me. I can't control for the group of patients that come to see me, but I oh man, honestly, so this is year 5. It's not as if everyone gets better, but let's say if I have 10 people. I would say 1, maybe 1.5 won't find the relief that we're looking for. Now the question is, do those 1.5 people not have a neck issue? I would say no. They likely still have their neck as a problem, but it's part of a bigger story. Now, does that story lead them to medication and this is just a neurological problem that needs to be managed that way? No, I don't think so. So a couple of things, like I've tried to work with, I work with other providers that are in different specialties, and those specialties and what they're trying to do is actually address a similar problem just from a different lens. So for example, tongue ties and oral development, upper palate development. These are things that are missed in a child as they develop and they grow. Their airway is restricted. And they get to be an adult and they're clenching and grinding their teeth. They go to the dentist, they find wear and tear in their teeth. And that's just because they're thrusting their jaw forward. They have a form of sleep apnea. Now, do we give them a CPAP? Well, in the Western medicine model, you give them a CPAP. In my world, do you give them a CPAP? No, you try to figure out why their airway was restricted and you try to improve their airway. Those patients oftentimes have headaches and migraines. Okay. Now, do they have a neck problem? Yeah. Does our approach work? Yeah, most of the time it does. Now, if it's not as effective as I want it to be, or if that tension is to a greater amount, like I can't have that much of an impact, then what I'm going to do is I'm going to send them to a breathing and airway specialist so that they can look through a cone beam CT and take them through a process of expanding their airway. Maybe they're treating a tongue tie, whatever that may be. Another patient that it popped into my head when you asked that question is they're actually, this may sound like I'm making this up, but I'm trying to think through this truthfully. I think there might only be one patient who I was like, you really, like, I can't really find much in your neck. Okay. So most people, 99% of people will have something that I can treat. Not all of those people will find the relief we're looking for. A small percentage won't. That doesn't mean they don't have a neck problem. Now, there are people that don't necessarily have a neck problem. And this one example comes to my mind, but what she was dealing with was like a mast cell activation. She had inflammation through her body. And so what was happening was her threshold was so low, like it was so low that she couldn't tolerate really anything. And so she would go home and she'd look at her phone for 15 minutes and it would trigger an aura. So in that scenario, her neck was dealing with tension. And the reason she was having symptoms because her threshold was so low, but it wasn't like a neck problem that I was going to be able to treat or help her with, just because it wasn't substantial enough for me to do anything. So what she needed was to get her inflammation under control. And so what I would say is most people with any sort of head or facial pain, we're seeing this problem. And then it's just a matter of how impactful this treatment approach is going to be in your scenario. And then if that doesn't work, I don't think I've ever sent someone to just like go to the medication route, because that feels like almost like we're giving up, like there's no hope type of thing. And so we always try to find another problem that can be pursued, and usually we can.
Yeah. The other side of that, though, I think, is your patients are selecting to you as well.
Right.
So,
Yep.
The people that medication works perfectly for are probably never going to see you. So there's that side of it. But
doesn't mean they couldn't still benefit. But I know what Tim's.
No,
Tim,
but
there's
there's a selection bias,
right?
which is
Right.
there's selection bias and everything. It's no big deal. Just have to understand it. The
Yep.
thing that I find really interesting, though, is the patient empowerment side. So, and this started I don't know, it's probably 15, 20 years ago. It would just trigger in my head because it would always bug me. And it was, I'm writing you a prescription for lisinopril because you have high blood pressure. And they're like, well, isn't there anything natural I can take? Yeah, it's called exercise and don't eat McDonald's. No,
Yeah.
I mean natural, like a vitamin. I'm like, okay, if it's natural, why does it look like a vitamin and not like a carrot?
Right.
Like
right.
that would be the way, but that was never an acceptable answer. But I'm like, why do these people want to spend the same or more amount of money on a vitamin because it's natural? And then if I got it, when I give you a prescription as a physician, there's something, I'm judging that there's something wrong with you that needs to be fixed, that is out of your control, and I'm doing something to fix it for you.
Right.
When you go to the store, natural health food store or wherever, and you buy vitamins or, and they may be helpful, they may not, who knows, and you take those, you're doing something for you to change your life. And that is super duper powerful. And I think we forget that. And this medicalization of absolutely everything. I mean, we have advertisements during football games for penile injections for Peyronie's disease that can cause rupture of your penis. And somehow they can still sell that drug for a tiny percentage of the population that has this, and spend millions of dollars advertising it on, during college football. And I'm like, I mean, I've seen 2 patients that actually complained about that in 30 years, but now there'll be bazillions because they advertise it, so it's the medicalization part. Instead of owning your health is your problem.
Right.
We're supposed to be there to come alongside you so that you can solve your own issues.
Yeah. Empowerment. Yeah, I think you nailed it. I actually like how you separated out the difference between, buying a vitamin versus a prescription medication. I think that's so true. I mean, people want to feel like they're supporting the natural process within their body rather than artificially masking something. We talk a lot in the physical therapy world. I use the analogy of the alarm going off in the house, but we don't want to if there's smoke and your smoke alarm's going off, you don't just like take the smoke alarm, rip the batteries out and like chuck it out the window. You address the fire, right? Like you figure out where your house is burning and you put it out. And so I think deep down people kind of feel that, like I feel like there's a problem in my body. I don't want to just like shut off the pain. So when it comes to empowerment, we've gone down this journey, and I think COVID was a catalyst to this, but I'm traditionally a manual therapist. So people have to come in, they lay down, I work on them. Outside of that, like during COVID, we were forced to start doing things virtually. And what we had to do is really just educate people on the problem they were having. And even that alone was impactful. I've had a few patients where we communicate virtually, and I will just validate their feeling that their neck is the problem. And they were going on this journey in their mind of like, they're dying and no one can find why they're dying, but the symptoms they were having were so debilitating and these neurologists can't figure it out. So I just must have this problem that modern medicine can't figure out. Like that's super stressful. And so to be able to just say like, hey, your neck, one, it's likely contributing to your symptoms, and two, our healthcare system isn't really set up to address it. And so there's a good chance it's been overlooked. For them to understand that is just like, boom, it's freeing. And I've seen people reduce their symptoms just by mentally understanding what's happening. And then aside from that, when you understand that your neck, as you go through life, time can either be on your side or against you, meaning our bodies have a level of stress from gravity it's constantly weighing on us. And so our musculoskeletal system has to work to keep us upright and moving and functioning. And so we're either sort of doing things that are therapeutic and helpful and working against that type of stress, and the stress is actually working in our favor, or we're letting that stress beat us up and we're increasing the amount of tension through our neck. And so a lot of our education is just teaching people on how to make that shift. Like, how can time now be on your side and working in your favor, as opposed to like gravity just pulling you down to the point where you have osteoporosis and you can't move your spine anymore and your neck is just stuck in this position. And so every little thing that we do throughout the day, we can probably make a shift in it being therapeutic, like helpful, or I don't like to use the word harmful, but harmful in a sense, in that it's playing into this neck problem that could be driving our symptoms.
I love it. I mean, it's making people aware. I mean, as we sit here, people mostly are listening to this podcast, not watching maybe the video on Rumble, but I'm always conscious of sitting up straight. And now I'm talking to you, I'm hunched over this desk. I got to get my neck in alignment because it's an issue, but I'm more cognizant of that, not just because you're here too, but what were you going to say?
No, I was going to say, be a smart ass and say, so did you teach them online during COVID how to manipulate their necks themselves? Because they're like, do you teach people, Well,
I would actually, for even answers, I was going to get to that because people love specifics, and not like you're going to, I don't know, give a trade secret away what you do, but people are going to want to, okay, when they come in there and you can manipulate their neck and work on it, but you also teach them things.
John will teach you how to touch yourself. That's what I'm getting to.
And I looked on your website.
Yeah,
and
let me clear that up then.
Yeah.
before we lose track of that comment. No, we're not teaching people how to treat themselves as far as the manual therapy techniques. Although I do, because of this problem and not being able to like have people come out for treatment, I did come up with a device that people can purchase.
I was going. I saw that.
Yeah. So it's pretty cool. I have a patent on it because it's the only device that actually is intended to restore function to the upper part of the neck. So we talk about movement, restoring motion to these joints. And so that's what the device does. And so with our virtual patients, what we do, well, if you're out of state, it's health coaching. So it does look a little bit different, but we send you the device, we take you through our courses, you work with a health coach, and it's pretty effective, but especially in person, when we're trying to get to the management phase of things, instead of people, carrying the medication in their purse, it's called the SAM device, but it's been able to replicate the same effect as like that abortive medication where they they start to feel their symptoms. They use the SAM device. Their symptoms reduce, maybe even resolve. I mean, I have a lot of patients that tell me that it's a great sort of management tool. So yeah, we're not teaching you how to. I guess if I have had it where a spouse will come. Yeah. Not quite there yet. Maybe we'll get there someday.
So the SAM device, like, do you have to lay on it? Do you
can you
do you
elaborate
strap
on
it
what it
around your
does
head?
compared to a neck stretcher or Joe Rogan's Vice thing that my son wants to buy?
Iron
the
neck.
Iron Neck.
The Iron Neck.
I don't know if you know what that is.
Oh, the Iron Neck. Is that a Joe Rogan thing? I guess I didn't know that.
He promotes it.
Yes. Well,
he promotes it.
He also, the very first thing that ever sponsored him back when he was worth $0 in the podcast world was Fleshlight. So you can put that in your pipe and smoke it for whatever it's worth. But he swears he likes this idea of training your neck strength wise, because when you're rolling, doing jiu-jitsu and getting kicked in the head, it's helpful to have a strong neck because you can that's his theory.
Yeah. I understand that now because I knew he did like mixed martial arts or something like that. So my device, you lay down on it. It has these two sort of prongs that put pressure. I mean, a lot of people with headaches and migraines kind of intuitively know this spot in the upper part of the neck I'm talking about that's kind of sensitive. Yeah. So that's where these two, I call them stoppers. That's where they put pressure. So you lay down on it, and then there's a head strap with some ropes and some pulleys, kind of just above your shoulder. The pulleys are sort of changing the angle of force. So when you pull through these ropes, it'll either rotate, or if you pull both of them, it'll nod your head. So you can picture these stoppers putting pressure here. And the idea is to have the movement be passive, meaning you're not actively turning your head. Because if you lay on those stoppers and you actively turn your head, those muscles are sort of acting as like a barrier to the joints. And so we need the muscles to relax to get to the joint itself. And so as you pull, and let's say you rotate to the right, you're able to do that by using your arm to pull your head. So your head's turning, it's putting pressure here, and you repeat that over and over. And it'll restore mobility, or at least put pressure and cause that area to kind of calm down. A lot of people would compare it to, like, you think of the two tennis balls that, you use to put pressure in that suboccipital area. Yep. This is a little bit more direct pressure, and then you have more control because you're using the head strap with the ropes and pulleys.
I love it. That technique I've had done on me by my chiropractor, who's very much into movement. And what you're describing is exactly where we will often find triggers in patients, or do trigger point injections or anesthesia there for relief, or we'll have people lay in the tennis balls, or even
it reminds me of what I do almost every day now, which is the Right, which is the same kind of thing, except it's digging into your abdomen,
psoas muscle,
and you can move it right down to your iliac crest. Where
that
you go
just
to
looks like a torture device.
Oh, it's delicious. It's like the Iron Maiden. So you get it right on your ilium, where your
hip bones for people listening,
and you can just kind of grind that bad boy out, and it just completely releases your psoas. And people forget how much of back pain. Lower back pain is hip flexors. Your hip flexors are all jacked up because people don't walk enough, they don't stretch enough, they don't do enough activity, and then you sit all day in an office.
He just needs to make a large device that's going to rotate your pelvis now while you're lying on that thing, I'm thinking.
Right. Full body.
So how much of what you have that device, and you can manually do that with patients. Do you use anything? So if someone's looking and they can't come to Colorado and they go online and see what you do, is there other things they should look for? Do you utilize certain stretches, heat? I'm going to say, I'm sure not acupuncture, but is certain massage? Is there certain strengthening techniques patients do at home? How about like a Denner roll, those stretching on cervical devices? What else? Is there any little tips or tricks you can utilize?
Yeah. So when people are looking for components of what we do, like we do utilize dry needling to help reduce muscle tension and things like that. Like I said, just if you're looking for a physical therapist that might be able to do this, search for a manual therapist, typically in the private practice setting. The good manual therapists are usually not attached to like a big hospital system. And oftentimes they got so fed up for working for someone else that they just did their own thing. But they're probably not very good at like branding or marketing themselves. So you got to search for them. and word of mouth might be the best way to find them. But as far as like tips or tricks for people at home, one of the low hanging fruit that I've seen a dramatic improvement in people's situations, especially if you have morning headaches or migraines, is just changing your sleep position, your sleep posture. So don't sleep on your stomach. Now, there are people that can sleep on their stomach and they're fine. But if you can picture this restriction in the upper part of your neck where half of your rotation should come from C1 and C2, and it's not there. Now your neck is compensating throughout the day. If you lie on your stomach and your head is turned to allow you to breathe, and you're in that position, for 6 to 8 hours, however long you sleep, it's going to be very aggravating on your neck. Oftentimes, your neck is going to be managing a certain amount of tension. And so any sort of like position outside of neutral when you sleep can be irritating. So even side sleepers that the bottom leg's straight, the top leg's bent, and they're kind of twisted a little bit, sometimes that can be problematic. And then side sleepers need a good like foam pillow. If you're on your back, the pillow can be thin. It doesn't really matter as much if you're on your back, but side sleepers, I always recommend a good like foam pillow because it'll hold its shape. It'll be a little thicker to account for the width of your shoulder.
Hey, so personal anecdote here, and for some people that have used those, because there's so many foam pillows, the memory foam to that stupid pocket peanut my pillow that Tim loves, that foam pillow I hate, but I cannot use them. And I know there's some people that don't like the memory foam because it causes a numb spot on my head. It sounds really weird, but I lay there and it's almost like it doesn't get circulate, like it's numbing, and I wake up and it just feels really uncomfortable. So I don't know if that's a rare thing. I'm just a freak of nature, but I have heard it from a couple of patients.
Speaking of freak of nature,
that's an issue. So is it just that it's not the right thickness? I have never been able to figure that out. I wasn't sure if you ever hear that.
Yeah. So oftentimes people will have hypersensitivities. So to touch, like if you think of this sort of chronic pain condition, and we talked about the hypersensitivities of other sensory inputs, sometimes that's a problem where people will lay on a pillow and they'll have ear pain, having numbness. So in that situation, what I'd probably do is try to find, like, we'd trial different pillows, because it's hard to reteach. Like, you can't sleep on your stomach. I don't let people sleep on their stomach. There's not really work around there. And so for most people, it's going to be side sleeping, and it is important to get the pillow right. So I'd probably just be trialing different pillows.
Sure.
Like, until we can solve that problem.
Well,
or maybe
I'm laughing. We have a closet full of pillows.
Yeah, because I sleep on my stomach. I can't sleep anywhere else.
Okay, there you go.
It's terrible. Like, I agree. Like, your head's off to the side. May's like, how do you breathe? And I go, well, not very well, apparently. So,
but I am I'm both. I like to
I'd love to sleep on my back
and my side, and it will just depend what's going on with my neck or etc. how I feel. But sometimes side's better, and then sometimes back is better. Now, the thing I've had happen, this is another question, and I've had patients, this is a rare thing, and I've been researching it, is I will fall asleep and then wake up at the exact same time in this cycle, like at 3 a.m., say, with a severe headache at the base of my occiput, at the bottom of my skull, that wakes me up like crazy. And I'm not sure if it's a circulatory thing, the way my head's tilted, and it's like restricting the blood vessels there, because they are there. And there is a condition where people can wake up in the middle of the night too with nighttime migraine at a certain time, and there's ties to tension, but also lack of believe it or not, caffeine. It's really weird, and hormonal stuff, because your hormones drop in the middle of the night. So I don't know if you had any thoughts or hear that at all with people with occipital or headache pain from sleeping on their back.
Yeah. In that situation, I always start, if there's any sort of sleeping issue, whether it's like alarm clock headaches like that, or it's people that wake up with headaches, I would always start with dialing in the sleep position, because the other avenues we go down are probably going to be like more costly and more time consuming for the patient to actually try to solve that. And so sleep position's number one. Outside of that, I'd probably think about airway, because your airway is going to, like, if you're having to open your airway, you're going to have to tilt your head back. So your neck will naturally do that. So there might be a little bit of tension there. Outside of that, yeah, I mean, then it's the environment that the pain's being received in. And like you
Right.
said, like, is there something with your hormones that needs to be looked at? So that would sort of be my line of reasoning there, or
Sure.
thinking.
So, okay, after the pillows situation and the manipulation, any other things you like to utilize for patients?
Yeah. So movement is medicine, as you said in the intro. People, I think, underestimate the impact that sitting has on their life.
Ah, yes.
And so it's kind of, I don't know, I don't want to call it a killer, but it kind of is a silent killer. Like, there's impacts on all these different systems within our body, but I'll just speak to the musculoskeletal system in our neck. So I mean, your head weighs about 10 to 12 pounds. So if you think of a bowling ball, right? It's heavy. Now, we don't necessarily feel that weight. I mean, some people, their neck is unstable enough where they really feel like their head is heavy. But for most of my patients, they don't necessarily come to me and say, like, my head just feels really heavy all the time. And so what we can do, our body's great at like compensating when we put our necks in weird positions, like we're leaning to one side on the couch, we're sitting staring at a computer, we're looking down at our phone. You know, if you're in middle school or high school, you're sitting on your bed doing your homework. Those things are asking your neck to do a ton of work. And so being in those positions itself isn't the problem. It's just the amount of time that we're in those positions. And so that's why movement is important. So it's not as if like there's a perfect posture necessarily. It's just the next posture is the best posture. So you should always be sort of dynamic throughout your day. And so if your head is forward in all these different positions, whether you're looking at your phone, you're on your computer, you're in a conversation, we need to do something intentional to get you out of that position. So sort of our framework for self-management is we want to do, the dentist gets everyone to brush their teeth and floss. We want everyone to do a couple things that really gets their body out of that position. Now that can be a few minutes in the morning, a few minutes in the evening. And then in the middle of your day, we want you to go on frequent walks. So as much as you can, get up and walk around, whether that's around your office, just around the room you're working in, or more intentional, like 20, 30, 40-minute walks outside. Walking can be really therapeutic, and usually it's low intensity enough that pretty much anyone with a headache or migraine can do it. Maybe if you're in the midst of one, then hold off, but find like a level of intensity. And here I'm adding a layer to the walking, but find a level of intensity with exercise that you can manage. So I just talked with another therapist about building your tolerance and your resiliency in your body to exercise itself. And so I would recommend that everyone have an exercise routine, a couple days a week, 3 days a week. And the type of exercise you do is less important. It's just finding something that your body can tolerate well and then building on that. So start small, maybe if it's 5-10 minutes, and build on that. Try to get to 20 minutes, 30 minutes, whether that's, you're walking or jogging on a treadmill, you're doing a stationary bike. And then in addition to exercise, just a few of the more common triggers when people are in an exercise program. If you are a cyclist, so you're forward, your head's cocked back. So that tension through that suboccipital area can be really hard to manage. So cycling is probably not one I'd say like jump into right away. And then if you go to the gym and you're like a bodybuilder and you like doing shoulders, oftentimes your shoulders are dysfunctional enough where that'll just add tension. So sometimes we need to rehab those things before we jump into exercise. But that's sort of the framework, is find something specific that gets you out of that forward posture, break up that posturing throughout the day with walks, and then incorporate regular exercise. And then of course, find someone that can help you with in-person care in your area.
Oh, that's excellent. For me and patients, I know that I lift weights, and there's certain, like anything overhead lifting with those traps and neck muscles, it's like I just give up, because every time I do it, even light weights, it just triggers it, and I know it's muscle.
Yeah, and the next day she has a headache, and I'm like, you were doing like military press, right? It's like, yeah.
But
Yeah.
But I like your point about just getting up and moving, because people don't, even just the little bits all the time helps your body reposition itself. We all know, I call it the American C posture of kids, and everybody's hunched over.
Yeah.
And and not aware. But even just getting up, being cognizant of moving, repositioning yourself, doing all these things all the time can make a big difference, even though you don't, it's small movement. So it's simple to do.
Yeah, it can. And like I said, you don't necessarily realize that it's detrimental to you in the moment. I mean,
Yeah.
generally people that sit at an office desk, I mean, I guess I could go 50-50 on this because some people do realize like, oh my gosh, the tension's increasing. But I'd say for the most part, people don't realize that their neck has tension that they're adding to it in that moment. They usually realize it when it's too late. You start to feel your symptoms, but what you should have done is prevented that by, incorporating some sort of movement throughout your day. This is going to be helpful for a lot of people. There are some people that finding an in-person provider, it might be necessary for them to sort of break this cycle that they have. But even if that's you, implementing these daily habits and little changes is going to be helpful just to your general health. And we talk about the environment that your brain is experiencing this pain in, you're going to see benefits there too.
Love it. I've so many helpful tips, tricks, and I think
That's it. No more motorcycle helmets for me. Done.
your head's heavy enough.
It is.
It doesn't need anything added
Done.
onto it.
Done. I don't need.
So therefore, just ride without
Plus,
one.
it's
right?
more wind resistant.
Just ride without one.
Like it's unbelievable. Like
That's the takeaway.
No,
You
it's
know,
all,
I've ridden over 700 miles in one day. You sit there and your head is doing
Oh
this
gosh.
it's like
like
a
that
bobblehead. Yeah.
for 15 hours.
So it's either a workout or a problem.
Oh my
Yeah.
gosh.
Yeah, crazy. So why don't you share with everybody your podcast as well as your website and where they can find you, since I know people will be super excited to try to get in contact with you.
Yeah. So my podcast is the Headache Doctor Podcast. The website is noveraheadachecenter.com, Novera, like new era, Novera. And on our website, we actually will have a promo code BS free for all your listeners. We have a masterclass, and that's sort of like the next step, I would say, without like actually interacting with us, if they just want to purchase that on the website. So it'll be 10% off our masterclass. And then on social media, it's funny, but apparently TikTok loves me. I've got a pretty good following on TikTok under the Headache Doctor.
I saw that.
Yeah. And then like Instagram and Facebook, it's Novera Headache Center.
Okay.
But yeah, that's how people can find me.
I will put all those links in the show notes, and we're on mostly Instagram and Facebook. Our social media manager does our TikTok because I can't do it. But anyway, I will link
Which
you
which
as
which
well,
means
as
the
well as-
Communist Chinese Party has 100% of all of our
Yeah.
data.
That's right. We just gave it to them.
Just
But I'll
kidding.
definitely link that.
But they don't have headaches, thankfully.
And,
It's a good thing.
Right.
and the promo code for the 10% off. How long will that last? Just so that I can know in the
podcasts. Yeah, podcasts are kind of evergreen, so we'll just keep that active. Just so.
wonderful.
Yeah. If anyone finds your podcast, even a year from now, and they want to go buy it, we'll honor that.
Thanks a lot. Spectacular. Any last words that you want to get in of anything critical that's on your mind that we didn't ask, as far as what you believe in this?
No, this was wonderful. I think we captured a lot of what's in my head. I'm just all about empowering and educating people. I mean, this problem is so rampant. I mean, in the communities that I'm in, I'll introduce myself. People say, "What do you do?" Well, I help people with headaches and migraines. It's like almost, probably half the time they're like, "Well, I have headaches and migraines," and the story is so common where people just are, they're losing hope. They're given medication after medication, and they don't even know that there's an alternative, or that there could be a source of this whole problem that they're dealing with. And so that alone, if your listeners take away, and then with that are able to pursue or just have a subtle shift in how they think about their own scenario, I think that alone will take them on this trajectory, this path that can lead them to finding some real relief outside of the medication world. And so that would be my sort of summary of what I'm on a mission to do.
I love it. I couldn't agree more. It's not, and I just want to say, as physicians, and if doctors who treat migraine who've had it. It's not that we're saying you don't need your medicine anymore, but it's helping them look for the root causes, things that can change and impact the severity of their illness, reduce their medications, maybe get rid of their medications, but tools that they can use, etc. So,
right. I mean, two things, this has been one of the themes of the podcast since we started, which is two things can be true at the same time. Yeah. May, we're not big fans of big pharma, but May takes an Eli Lilly drug that's really helped their headaches. And we did an entire show on it. Two things can be true at the same time. The pharmaceutical industry can be kind of corrupt and it can be super helpful at the same time. Right. Pablo Escobar sent a lot of people to college. So,
that's a weird way to get to it, but anyway.
Well, it's true. John Gotti, bought a lot of turkeys on Thanksgiving for people in his neighborhood. So, yes. So on that complete bunny trail, we will say thank you to you once again. And this has been outstanding. I know there's a lot of people that listen to us that have this problem, and to know that there's hope and to know that there's a way at least to a better life, maybe not completely headache free, that does not involve a ton of meds is just spectacular news. So thank you again, Jono.
Yeah. Thanks for having me on the podcast.
Have you heard of hyperbaric therapy?
If you want better circulation, oxygenation, or respiration,
turn up the volume.
Everyone appreciates the increased energy and clarity.
Athletes, say goodbye to those PRs because you're going to blast
So
them.
how does it work?
We load your body with oxygen.
That means
less inflammation,
fewer allergies,
faster healing, and more.
Come see us, 1200 Executive Parkway.
The Upside Down building.
Call us, 541-636-3278.
That's 541-636-3278.
We have some incredible deals.
Heal, build, and thrive
with New Leaf Hyperbarics.
Got air?
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.